The content of this podcast is based on medical fact and evidence-based practice from credible authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and FlightBridgeED in their entirety. This is the FlightBridgeED Podcast, critical care and emergency medicine education for nurses and paramedics. Here's your host, Eric Bauer.
Hey everybody, welcome back to the FlightBridgeED Podcast. Great to have you. If you're new to the show, we really are excited that you have chosen us, and we know your time is precious. If you've been a long-time listener, as always, we're really excited that you've stayed with us and partnered with us for long-term. Continue with the great emails and feedback and ideas. I really appreciate those things. It really helps me decide on new content, things that people get real excited about. And obviously, I don't have all the answers. And I may think that a topic is important. It may be important to me, but it may not be important to somebody else. So very important that you communicate with me, and as everybody know, you can reach me at eric.bauer@flightbridgeed.com. If you've emailed me in the past, you know that I do respond to my emails very quickly, and you can always call or text me as well. As I said, we're going to continue with our two-part series on traumatic brain injury. In the first series, we covered subdural bleeds, we covered epidural bleeds, and we covered the overall kind of basis regarding pathophysiology for traumatic brain injury, different things that we really need to focus on, and kind of a review of anatomy and physiology. Today, what we're going to do in part two is we're going to specifically look at kind of below that dura mater. So we're going to look at subarachnoid hemorrhages. We're going to look at intraventricular hemorrhages, intracerebral hemorrhages, or what's called parenchymal hemorrhages, and kind of discuss the different treatment options related to those specific bleeds or traumatic brain injury patients. So let's start off with looking at a subarachnoid hemorrhage. Subarachnoid hemorrhages are something that are potentially highly fatal. They can present based on what's called a berry aneurysm, or they can be manifested secondary to trauma, blunt force or penetrating trauma. So the important thing to kind of realize is that we have two areas of our brain. Obviously, we have our cerebrum, our cerebellum, and kind of lying right in the center of those two areas of the brain, if you separated those areas, you would have what's called the circle of Willis. That circle of Willis is very identifiable on a CT scan. And as I said in the part one of our two-part series, and if you've already referenced it, you can go on to the website, go to the blog section, and open up that area based on the podcast of part one, and you can see that I've placed CT scans of subdural and epidural bleeds, and I'll do the same thing for subarachnoid, intraventricular, intracerebral type hemorrhages, and try to identify and point out the different things that I'm discussing in the podcast. But when we look at a CT scan, like I said, it's very identifiable as far as the circle of Willis goes, specifically when you see bleeding, and you can identify the bleeding. And because the circle of Willis looks like just this big kind of oblong circle with branches off of it, the blood will actually follow and fill those tracks. It's important to know that a lot of subarachnoid hemorrhages are caused from what's called a berry aneurysm. And a berry aneurysm is named for these little arteries in the brain that kind of look like little berries that branch off of that circle of Willis. Primarily, 40% of all berry aneurysms occur from what's called the anterior communicating artery. So a lot of times these are secondary to patients with vascular disease, patients that have smoked, and they've actually looked at different literature and studies, and they've identified that it could be based on genetics. It could just be a pre-genetic disposition that these patients have a weakened circle of Willis, or these vessels in the circle of Willis are potentially weakened. One of the things that you have to understand is because of a hypertensive event, these little arteries that come off of that circle of Willis, that main basilar, what's called the basilar artery that circles around and ends up terminating at the very top, to what's called the anterior cerebral artery, and then you'll see that there's an anterior communicating artery that comes off of that, and it comes off of that at like a 90-degree angle. And all those little bifurcations like that, that's a weak area. So anytime you have a hypertensive crisis, or you have a patient that's already has extensive peripheral vascular disease, any sudden spike, anything like that can cause that little artery to burst. And as I said, 40% of all subarachnoid hemorrhages resulting from a Berry aneurysm is based on that anterior communicating artery. So we have to understand that we treat these patients a little bit differently. As I said, we also see subarachnoid hemorrhages in trauma. And it's actually the most common cause of subarachnoid hemorrhages. This is something that we have to treat aggressively as far as airway management goes based on the presentation. These patients may have a normal mentation, they may have a perfect GCS, or they may be completely comatose and unresponsive. So we have to treat them based on what you're finding, the presentations. Airway management, advanced airway management with RSI is obviously recommended to secure that airway. We never want these patients to get into a situation where you can't control that airway. You don't want any vomiting. You don't want any potential aspiration. So again, as I've said many, many times on podcasts, I am very aggressive with airway management. You may disagree. That's all right. This is just my view. And I think that in our field, especially if you're in the HIMSS environment and you're flying these patients in aircrafts, there's a lot of factors that we have to consider that you don't consider in an ED or even in the back of the ambulance, just based on assessment and access and things like that. And I think it's always a really good rule of thumb to always err on the side of caution and protect somebody's airway rather than be reactive when that airway decompensates and collapses. We never want those sentinel events or those hypoxic events. So again, I always feel like it's best to treat their airway and protect that airway. Sometimes these subarachnoid hemorrhages will actually manifest secondary to subdurals. You may have subdural subarachnoid in conjunction. These patients have a high likelihood, if ICP increases significantly, to go into seizures. And then obviously, if this is a manifestation from that Berry aneurysm, as we stated earlier, they may have a severe headache, they may have projectile vomiting. And so we have to, again, base our treatment on the initial assessment, the initial history. When you look at this from the perspective of the HIMSS environment, again, if this is a scene flight, you're probably not going to be landing at somebody's front door, so you're going to have to get a lot of information from the ground paramedic that activated the helicopter. And I think it's, again, very, very important that we always reduce the stigma that I know some areas of the United States, and I think any of us being type A, we can all come across arrogant. I think that's something that I look at in myself early on in my career, that even not meaning to be that way, even just being confident in my job or being quiet. I think a lot of us are introverts. I'm definitely an introverted person. So just being quiet, being kind of shy, I think you can come across the wrong way. And I think it's important to understand that when we land at these scene flight locations and we enter the back of the ambulance and we're discussing things with the paramedic, that we value their clinical knowledge, we value their assessment, what they saw on scene and things like that. And I think we can really gauge our treatment based on that. Like I said, a lot of times these are Berry aneurysms. And if you had a patient that had a sudden onset headache, projectile vomiting, a lot of times it is a secondary issue from this circle of Willis off that anterior communicating artery. 40%. It's a very high likelihood that it's that area. And so why is that important? Why is it important to get that information? Well, our goal for maintaining a systolic blood pressure is very, very important in these patients. And if these are secondary to a hypertensive event, as I stated regarding a medical presentation rather than a trauma situation, our goal is going to be to try to identify what type of bleed this is. And obviously, we don't have CT scans or CT scanners in our helicopter. So we need to try to have that high index of suspicion and treat these patients appropriately. The thing that we have to understand about a subarachnoid hemorrhage is that they are highly susceptible to rebleeding because these little Berry what looks like a little berry that comes off of that circle of Willis can be so weak, and they're so delicate, especially to high pressure changes and things like that. We never want to have a mean arterial pressure greater than 130, but specifically what we see with most protocols, or what I've identified with most protocols around the United States and really through the world, is that subarachnoid hemorrhage needs to have a systolic blood pressure no greater than 140 millimeters of mercury. And so if these patients manifest from a hypertensive event, obviously they probably have uncontrolled hypertension. So our goal is going to be to aggressively treat that blood pressure and get it down to that manageable level of 140 systolic. And I think that that's very, very important. If we can't maintain that blood pressure and we're fighting against that, or we don't identify this early, these patients can have a huge amount of ICP change based on, remember, that Monroe-Kelly hypothesis, where we said that you have just the perfect amount of blood, perfect amount of cerebrospinal fluid, and we obviously have our brain in that compartment. And we have to give or take based on changes in ICP. Obviously, if you have a subarachnoid hemorrhage and it's from a berry aneurysm and you're bleeding out in your brain, that blood is going to overtake everything and your ICP is going to increase. So we don't want our patients to herniate. We don't want our patients to go into a seizure. So again, early identification, if possible, early treatment is very, very essential in these patients. So what medications would be good in this context? Well, we have a whole bunch of medications that we can use for the treatment of hypertension related to traumatic brain injuries, whether that's esmolol, whether that's cardine, whether that's nitroprusside, whether that's just push dose labetalol. We can utilize any one of these based on what your current protocols are, what your current access to those medications are. I would say that a lot of companies, especially critical care providing companies, have the access to all of those medications. Esmolol, remember, is a medication that is very fast acting. It's a beta-1 agonist, and it's something that you bolus and then you start a drip. At that point, if you don't see a reduction in blood pressure, you can rebolus that patient, and then you can increase that drip. The other medication that is very standard and is very easy to use is going to be your cardine. And cardine is very easy to use. It's 2.5 milligrams per hour IV. You're going to do this, and then you can increase this by 2.5 milligrams an hour every 5 minutes to a max of 15 milligrams per hour. I've used this many times. I've found it to be very easy to use, very therapeutic, and so that's another medication. And then obviously we can easily go to a push dose medication like labetalol. Labetalol is great. Dosing, again, is specific to your protocol, but from what I've normally seen, it's 10 to 20 milligrams for your first dose, and then you continually double whatever dose you start with until you reach 300 milligrams or you reach your target systolic blood pressure. So, if you have maybe a short flight time, you're worried about having to set up the drip and take that extra time, starting with labetalol is a great option, and I think it's a great tool to have in addition to these drips. Another really good medication is going to be nitroprusside, and nitroprusside is a medication that I often discuss with colleagues of mine. One specifically is my buddy, my good friend, Tony Harrison. And, he has very strong opinions for nitroprusside. I think a lot of it manifests from his experience in the ICU, but I think it's obviously warranted. That experience is very valuable. We have to remember that nitroprusside works both on the arterial side and the venous side, so both the preload and afterload side. It's a great medication. It's something you're not going to want to use in a pregnancy patient, so always be cautious there. But the dosing range is 0.5 to 10 mics per kilogram a minute, and you can increase or decrease that every 5 minutes. I've actually had very good luck with this based on just going the lowest dose at 0.5 mics per kilogram per minute. So I've had a lot of success there based on that lower dose. But whatever medication you use, the whole point is that we have to try to get this patient down to that systolic blood pressure as quickly as possible. We still want to perfuse the brain. We still want to be able to handle that and do that appropriately, but we don't want them to herniate. So again, very, very important to remember the differences between subarachnoid, subdural, and epidural. We have different goals for each one of those patients. When we continue on below that subarachnoid area, we have bleeds that are called intraventricular. They could be intracerebral, or they could be what's called a parenchymal bleed. The intracerebral parenchymal bleeds are pretty synonymous to, utilizing the same word, and they're meaning the same thing from what I've read and been taught. Intraventricular is often a presentation where that bleeding is now bleeding into those ventricles, the third and fourth ventricles. This is going to, obviously be a big deal as far as ICP increases, causes hydrocephalus. These patients would need to be treated a little bit differently than a patient with a subarachnoid hemorrhage. So based on that, when we discuss these different bleeds, we can kind of focus on each one specifically. Intracerebral hemorrhages are, again, called parenchymal hemorrhages. So it's just bleeding in that just main part of the brain, in that parenchymal brain tissue. If you kind of go below that, and we're talking about an intraventricular hemorrhage, intraventricular hemorrhages are looked at a little bit differently. Obviously, we focus on perfusing the brain, but intraventricular hemorrhages don't have a very high likelihood of rebleeding like we see in subarachnoid hemorrhages. Now, again, based on different protocols, I've seen protocols where they've said we want to maintain a systolic blood pressure in an intraventricular hemorrhage of 160, and I've seen protocols of 180. I think the point is that we want to get that blood pressure down to where we reduce ICP, but we still optimize perfusion, right? We still want cerebral perfusion. And again, a lot of that cerebral perfusion is going to be based on our cardiac output, maintaining good oxygenation, airway management. Remember, cardiac output, 25% of our cardiac output comes from, or I should say goes to our brain. So we've got to maintain that good oxygenation. We also have to maintain the proper kind of balance in our chemical regulation, and that's our CO2. And our CO2, we know, either causes vasoconstriction or vasodilation based on the levels, with vasoconstriction being based on a patient with a low CO2 range, right? So a hypocapnic patient. And that's why we always, again, use that goal of 30 to 35, keep it on that low end, just to maintain some vasoconstriction. We still want perfusion, we still want blood flow, but we don't want these patients to have too much, where we would see, in contrast, a patient with a high amount of CO2 or a hypercapnic patient, they would have vasodilation. So again, we have to kind of use all these tools we have: airway management, oxygenation, ventilation, pain management, right? Pain is a big player in increasing ICP. Using correct medications that are going to optimize cerebral perfusion and maybe reduce pain. And there's a lot of literature right now on utilizing really low amounts of benzos, and instead using a lot of ketamine, using a lot of actually Diprovan. I know Diprovan is not my favorite medication in transport, but there's a lot of studies out there, a lot of literature out there that shows in a hospital setting, in an ICU, that Diprovan really does improve the patients. It really does optimize cerebral perfusion. It really keeps them well sedated, and is there's a lot of benefits to Diprovan. Again, I don't think Diprovan is a very good medication in transport. I think there's a lot of little things that can happen where, because of the short half-life, we have potential issues with it, and I often will DC Diprovan in transport and go with more pain management with my fentanyl, utilize ketamine if it's warranted, or utilize Versed. But again, there's a lot of studies out there that benzos cause delirium. Is there studies out there right now that show that in the acute phase, in the pre-hospital environment, that benzos cause any long-term effects? I would probably argue no. This is more long-term. We're talking days in the ICU, but I think there's a lot of other things that kind of play into that delirium and that psychosis. just not having windows in your room, being in that sedated state for long periods of time, kind of forgetting all about time and not knowing if it's day or night. There's a lot of things that play into that overall delirium and psychosis. So I really don't think that there's a big issue in our pre-hospital environment with using benzos like Versed specifically. We use a lot of Versed over other benzos for sedation. So whatever you use, I think it's important to maintain good sedation, good pain management to reduce the levels of ICP. One of the things we have to also remember is it's essential to maintain that cerebral perfusion pressure of at least 70 in these patients. Remember, 60 in those pediatric patients. And when you get below 60, specifically in that 50 range, that's where you're really going to start seeing ischemic changes in the brain or infarct. And so again, if in contrast, this was a traumatic brain injury patient related to a multisystems trauma and you had massive hemorrhage, you also identified you had either a intracerebral, intraventricular, or subarachnoid potentially. Obviously, some type of head injury. I think it would be difficult to really focus on which one, but whatever you would, I guess, assume to have, you have to maintain that cerebral perfusion. And so again, in that context, if we have to maintain a cerebral perfusion pressure of at least 70, and ICP ranges based on different literature is 0 to 15 or 0 to 20, we've got to maintain a MAP blood pressure, mean arterial pressure of at least 90 in these patients, right? So we're talking a lot about this high aspect, these hypertensive patients, but we have to, in contrast, think about these lows. And so that means we have to start pressors. A perfect pressor for these patients is Levophed. And I know that there's a lot of argument. I think a lot of it's misconception. It's maybe not understanding everything full circle of, well, hey, you should never start a pressor on a trauma patient. And I was told this early in my paramedic career, just as a ground paramedic. But there's a lot of things you have to consider there. Yes, they may be hemorrhaging. Yes, they may be volume depleted. They may have a container failure, things like that. But overall, if you can get them to a surgeon and you get them to a facility and a surgeon that can fix those issues, a spleen, a liver, something like that, but we don't manifest proper cerebral perfusion and oxygenation of the brain, what's the point? And so we have to remember that starting a pressor on these patients is a huge thing. And I read a lot of charts, and this is a forgotten thing. We got to do this. This has to be an absolute priority. Like I said in part 1, anytime you have a hypoxic event or a hypotensive event, each one of those causes an approximate 50% mortality rate. So those are big secondary brain injury issues. So again, maintain that cerebral perfusion pressure of at least 90. Again, keep that MAP blood pressure at least 90 in these patients, and that's going to optimize cerebral perfusion, at least give you a cerebral perfusion pressure of 70. So be aggressive with that. Make sure that you do consider that. As I said, for this intraventricular hemorrhage, really anything below that subarachnoid area, intracerebral, again, there's different arguments, but I think for the most part, keeping that blood pressure, the systolic blood pressure in the 160 range from what I've seen, again, I've seen some protocols at 180, is going to be the best option. One of the things you may see if you ever transfer a patient from a hospital for whatever reason, one of the things that they will do after that 96-hour mark, if this is a spontaneous bleed, right, or a bleed where they've got it under control, the bleeding has stopped, whether this is traumatic or some type of a vessel in the brain that's secondary to an aneurysm, they'll actually put a drain in. They'll drain that blood out of those ventricles, and they'll actually put TPA in that drain to make sure that it stays patent. And so remember, they're not putting TPA inside those ventricles, right? They're not going to do that. It's just to maintain patency in the drain to get rid of that extra blood that's accumulated in those ventricles. So that's a very, very important thing to remember. So I think, we've talked about subdural bleeds. We've talked about the importance of identifying a subdural bleed, and that subdural bleeds can manifest from, a very acute, sudden onset from trauma, where they're going to have an immediate loss of consciousness, or it can manifest over months. We know that there's a very high potential mortality rate, and these patients need to be treated aggressively as far as airway management goes. We want to focus on keeping that patient a little bit cellularly dry. We have to keep that serum osmolality at a level of about 320. Remember, that's on the kind of the high side, that dry side. And we always want to maintain a sodium level. In a lot of hospitals now, they're doing this rather than going mannitol, but maintaining that sodium level about 155. So remember, by keeping that sodium level high, we cause a shift of water out of the cell, and that causes that cell to shrink, which reduces edema. And then we want to make sure we keep them well sedated. When you compare this to an epidural bleed, remember that epidural bleeds manifest much differently, that they're very highly survivable, very low mortality rate, but we have to identify these and treat these patients. I think one of the things we've all seen in mainstream news is if you've ever seen the movies Taken, or he's in Star Wars, Liam Neeson's wife, from what I've read, had a crash skiing, and she hit her head, had a brief loss of consciousness. She woke up very quickly, and they took her home. And she, instead of going to dinner with the family, she said, "You know what? I just want to take a nap. I want to lay down for a while. I'm a little bit tired." And when they came back from dinner, they found her deceased. And so, if she maybe would have went to a facility that could have identified this instead of staying home, going to sleep, this epidural bleed could have been drained off and taken care of. And so she died from that epidural bleed, causing increased ICP and herniation ultimately, and not allowing her viable life, obviously. So epidural bleeds, remember, are going to manifest with a level of consciousness. Then we're going to have a period of lucidness, and then we're going to start having an altered mentation where it will lead to ultimate unconsciousness in these patients. When that happens, when they go from that period of lucidness and they start manifesting into that secondary level of consciousness where it's decreasing, that's where you're going to start having major airway issues. And so it's always best to intervene very early in those patients. So again, be proactive, not reactive. And then we talked about subarachnoid hemorrhages. Subarachnoid hemorrhages, again, are based on that anterior communicating artery. 40% of all Barry aneurysms manifest from that small little artery off the circle of Willis. I will, again, put a CT scan on the website showing a subarachnoid hemorrhage. And we know our systolic blood pressure goal is going to be 140 because of the high incidence of rebleeding. Remember, we got a whole multitude of medications from nipride, esmolol, labetalol, or cardine to try to bring these patients down to a level of 140 systolic. And then when we think about intraventricular or parenchymal hemorrhages, trying to keep that blood pressure a little bit higher, that needs a little bit more perfusion in that area of the brain, is going to be about 160 systolic to 180 systolic, depending on your protocol or what you read. But I think we have to remember there's not that incidence of rebleeding. That's not something that we worry about as much. And our whole focus is to try to still perfuse the brain. So we have to think about secondary ways we do that with our CO2 regulation, making sure that CO2 is down to a range that optimizes this, which is 30 to 35. And then any secondary things that could cause harm to our patient. Obviously, airway management, oxygenation, no hypoxic events, no sentinel events in regards to airway management, and then no hypotensive events in identifying that, we may have a trauma patient that's multi-system. They may have massive hemorrhage, but we have to also identify traumatic brain injury patients kind of supersede that permissive hypotension mindset. And so we got to maintain that blood pressure a little bit higher, and that goal is right around 90 millimeters of mercury. So that's all I have for this podcast. Again, I want to thank everybody for liking part one. It's really, really exciting to see after 3 years now putting out material. This is going to be, I think, podcast number 80, I believe, that we still are putting out material that's relevant to the industry and that people are enjoying that. So as always, I appreciate everybody, and continue sending me emails and ideas. And if you ever have any questions or areas that you're working on, you need help with, again, that's why I'm here. Just please email me and I will give you my time. So until next time, I'll talk to you soon.
This has been a production of the FlightBridgeED Podcast, leading the way in pre-hospital critical care and emergency medicine education.